Welcome everyone to the SAB's April webinar, Maximizing Diagnostic Yield through Real-Time Intraoperative 3D Imaging during Robotic-Assisted Bronchoscopy, sponsored by Body Vision Medical. Before we get started, there are a few housekeeping items to go over. You all have joined in a listen-only mode. You may ask questions throughout the presentation using the question drop-down arrow feature that is all located on your control panel. We will address all the questions after the lecture. At this time, I will hand it over to Dr. Novari, and he will get us started on tonight's lecture.
Thank you to the SAB and for giving me the opportunity to be involved in tonight's discussion. I hope the audience finds it useful. I'm accompanied by one of my mentors for many years, an advanced bronchoscopist and pulmonologist at University of Chicago, Dr. Kyle Hogarth, and I'm really excited to be involved with this talk, and also thank you to Body Vision for allowing us to do this. So I'll start with my disclaimers. I'm a proctor for Intuitive Surgical, and I do have some research funding from Body Vision Medical. Okay, so when we look at the timeline of what has been available to us as bronchoscopists for many years, for those that came before 2015, which is when I was in training, we used Varon and the Super Dimension system. But both of these systems have really been around for quite some time, and they have had some modified approaches and some updates in their software over the years, which has helped. But suffice it to say that around 2018, this is where we were. And so it's exciting to have platforms that allow us to go to the periphery to do lung nodule biopsy and other advanced things, and hopefully someday take a therapeutic approach to lung cancer. But what's important to note is that when you look at a meta-analysis that was done by Atul Mehta and others, they looked at papers going back to 2005, and over a 12-year period, a survey of the literature showed that the diagnostic yield on average hovers around 72%. And I think that's important because we always hear about what our IR colleagues are able to achieve with TTNA or ultrasound guided biopsies, and we'll talk a little bit about their yield and how it compares to ours. So in looking at other papers that have been published over the years, I think this was a seminal one, the Navigate trial. That was published several years ago and looked at patients from 2015 to 2016. And what I really like about this paper in particular is the number of cases they looked at, namely 1,215 subjects. And it was done at a multitude of private community type setting facilities, as well as academic centers by all the people listed there for the Navigate study. And whether you define it as a liberal approach to diagnosis or a conservative approach, and what I mean by that is after a year they followed up on all these patients, and what they saw was that some of them who had inflammatory cells 12 months earlier actually had nodules that disappeared or shrank in size, and then those that had malignant cells, they obviously considered true positives. So they looked at all the true positives and true negatives divided by all attempted biopsies, and on average, the yield was about 72.9%. So not bad, but really when you look at a navigational platform that had been around for over a decade, it's not as good as what we would hope with as compared to our IR colleagues. Now, when you do a subgroup analysis on this paper and you evaluate the nodules that they had gone after, you really have to take your hat off and give them credit. 49% of the lesions were under 2 centimeters. So a good number were small, and 58% were upper lobe. And then half of the lesions did not have a bronchus sign, with about 2/3 in the peripheral, third of the lung, and 25% abutting the pleura. So not the easiest targets to go after, but we still see a yield around 72.9%. So speaking of TTNA and IR guided procedures, there's this really nice paper by Di Bardino, Yarmus, and Seaman that was published several years ago where they looked at approximately 490 articles and combed through and found about 10% that met inclusion and exclusion criteria. Most of the patients had a CT-guided transthoracic biopsy. Some patients had an ultrasound-guided biopsy, and then some had electromagnetic TTNA, which was a pilot study. But if you look at their yields, this is what really separates them from us. You have a 92% yield with the CT guided group, 88.7% for ultrasound guided group, and the navigational group, or the electromagnetic navigation group, had about an 83% yield. So when I see patients, and I have a patient with a small peripheral pulmonary nodule, I know that we're part of a cohort that is involved with the Veritas trial, where we're comparing peripheral lung lesions, doing a TTNA versus Super D guided bronchoscopy with fluoronav. One of the things that always comes up to me is, well, what are the pros and cons? And I think one of the things that separates us from the IR colleagues is the pneumothorax rate. So we're all aware that 20.5% is pretty high, and this is something real that we quote to our patients. Hemorrhage is listed as a low complication rate, but there are other advantages. There was part of a group chat where people were discussing the benefits of doing EBUS almost universally on patients because of the extent of occult disease in the mediastinum. So I think the number of bronchoscopies continues to increase as we get more and more patients for primary diagnosis, and also other things such as molecular markers and PDL1 status. But when we look at what we have available up to this point, with a rate of success about 72.8 or 9% as compared to 92%, it makes us want something more. And so since 2018, we've kind of been blessed with Ion by Intuitive, RS by Monarch, where we have now 2 robotic systems, one that works itself by shape sensing, picking up to 1,400 points per second. Another one that still uses an electromagnetic force to reach peripheral lung lesions. Now, why is it that we would think that these 2 systems could potentially increase our yield? I can tell you anecdotally, I use Ion, and Dr. Hogarth, I know, has extensive experience with Monarch. In my opinion, one of the first things I noticed within 5 cases of using Ion was the ability to articulate at a very high angle, 90 degrees, 180 degrees, to have stability with our catheters, and the ability to have, for the first time, an optic visualization all the way out to the periphery when you're looking at lung nodules. So I think this was a first in the field of advanced bronchoscopy, and really has been a game changer. Does that change your results, however? So this was a really nice study that was done, or a group of studies, I should say. Of the last 3, 2 of them were, if I recall, done with Monarch, 1 was done with Ion. And what we see here is there's a decent number of patients they looked at. The follow-up period was at least 6 months, up to a year. And most of these patients, they deemed successful navigations, whether they define that by rebus view or virtual target confirmation. And the majority had a bronchus sign, but again, almost 69 to 77% at most had reported diagnostic yield. And so while these were all generation version 1 of the robot, it still leaves us to wonder, why is it that we can't get adequate tissue or better yield, despite the fact that we have this amazing advancement when it comes to peripheral lung nodule biopsy. And so we know that the robot is great at localization, but it's clear, at least based on this, this slide, that that does not translate to higher diagnostic yield. So, next slide. So when we look at this, we ask ourselves, well, is it system dependent? Well, I think the last slide kind of showed that's not the case. Ion by Intuitive is shown here, Super Dimension in the middle. I didn't include one for Varin, RS by Monarch. And I think the problem is that there's something inherent here, whether you're looking at a teal ball, a green ball, a yellow ball. All of these nodules or targets are based on a preoperative CT scan. And so when we're using a preoperative CT scan to establish our target, we're really establishing a virtual target, a lesion that was present 2 weeks ago, a month ago, 2 days ago if you're lucky, or on the day of with Varin. And so even with the most novel navigational platforms, especially as we go after smaller and smaller nodules, there's a phenomenon that's called CT to body divergence that we believe is leading to lower diagnostic yield. So what is CT to body divergence? Well, first of all, there's ways to improve it, but let me define it. So when you have a scan that's done, say a month earlier, we all know the arms are in a upright position as opposed to the position of the patient during the procedure where they're in a supine position with the arms on the side. And so just this morning when I did a bronchoscopy, I was paying attention to the induction phase of anesthesia, and it took over 5 minutes. There was taking their time, bag mask, ventilating, using 100% oxygen, and inevitably causing atelectasis. So all these features cause an issue with where your actual target is on the day of the procedure as compared to where it was on a preoperative CT scan. So where our virtual target is as compared to our actual target may be in a totally different environment. And so ways we can improve this, Mike Pritchett and others have published a nice paper discussing how we should all try to utilize higher levels of PEEP, 10 to 15, depending on body habitus and whether you're going after a lower lobe lesion. Decreasing procedure time obviously would be helpful. Reducing bleeding can help. But one issue I had just this morning as an anecdote was I went after a left lower lobe lesion that was kind of tucked away medially and posteriorly. And the first view I had with my rebus was this beautiful concentric view. And then the subsequent views I was getting looked a little different. And so as you can imagine, atelectasis can give you a rebus view, but that doesn't mean you've actually localized and you're in the lesion. So just after 2 or 3 passes, I already could tell I was developing some CT to body divergence on my fluoroscopic scan. I was not using any other augmented fluoro for today's case. So this next slide, I think, kind of illustrates that nicely, where they looked at CT pre-procedure versus CT intra-procedure. So the planning CT versus cone beam CT intraoperatively. Now, most of us, including myself, don't have access to cone beam CT, so we don't have that advantage. But we do know that based on this study that the average divergence for upper lobe lesions is 12 millimeters and upwards of 3 centimeters. And for non-upper lobe lesions, it's on average 18 millimeters divergence and up to a maximum of 28 millimeters. Now, when we're going after a lung mass, that may not seem as important. If I get the periphery and I'm still within the target, that's totally fine. But as more of us are going after lung nodules and we're getting referrals for 1.1, 1, sometimes 9 millimeter nodules, we want to make sure that every bit of divergence is reduced. And so preoperative CT versus actual CT, as you can see here, there's we have this sophisticated way of getting out to these nodules, but we want to make sure that we're at the actual target, which is a rate limiting factor, regardless of the system that you're using. And so EM-based systems are also going to have this issue. This is a slide courtesy of Dr. Kyle Hogarth. So on the left here, we see a yellow virtual target. In the middle, the yellow target is shown on slide 2. But what we saw, at least what was seen in this case, was that there was a several centimeter divergence, and with movements that were made or adjustments that were made with lung vision, body vision, a radial EBUS view was obtained, and adequate tissue was then acquired for diagnosis. And so I really like this next slide, which kind of illustrates what happens. And so before, this was done again by Mike Pritchett, Krish Bhadra, and Jennifer Mattingly. And so what they did is they looked at virtual targets as obtained from a superdimension navigational bronchoscopy. And during the procedure, they did an intraoperative cone beam CT spin to obtain nodule location. And what they found was that before, when they compared the virtual target to the actual target, almost a third of the cases had 0% overlap. And I think that's worth looking at with greater detail. And about 68% of the cases, there was an overlap between the virtual target and the actual target. But the majority of those had only 0 to 25% overlap, or at most 50% overlap. And so the smaller the nodule, the greater the impact of CT to body divergence. And that's kind of the take home from this slide. Shape sensing technologies. I'm a huge fan of using ION. We have it at 2 of the 3 hospitals I work at. But this system, while it's fantastic at articulation, ability to go into the periphery, is not immune from CT to body divergence. The image on the bottom left illustrates that the virtual target is essentially 0 millimeters away, or that's what the AI is telling us. We're 0 millimeters away from the nodule. But as you can see, the catheter is several centimeters away from the actual target as obtained on an intraoperative lung vision scan, tomosynthesis. And so with adjustments that were made, again, a radial view was obtained, but you can see that the virtual target is now 18 millimeters away. So the virtual target and the actual target do not always correlate. Just to further emphasize this, another paper by Mike Pritchett and others, now there are some theories that the nodules may move in a certain direction or amplitude or distance. It's not the case. The nodule movement intraprocedurally is going to be almost random and unpredictable. And in this study, almost half of the cases showed divergences of 10 to 35 millimeters. So that's a lot. You know, even if you're going after a 2 centimeter nodule, if you have 20 millimeter divergence, you're going to completely miss the target. Perhaps this explains why our yields tend to be around 70 to 77%, regardless of the system that you're using. So what is our current landscape and where do we want to go? Well, currently with our navigation platforms, whether you're using electromagnetic, shape sensing, or augmenting fluoroscopy, which you can do with certain systems, including body vision, or intraoperative imaging, static imaging I would call, or radial EBUS versus real-time imaging with cone beam CT or body vision, is I think where we, as a group of advanced bronchoscopy specialists, want to kind of delve into. And so what is body vision? So body vision is a real-time intraoperative imaging system. I think the biggest benefit here, and you'll hear this a little bit later as well, is that it can be incorporated essentially with any C-arm. We use the GE 9900 OEC model. I've seen it used with different systems. It can be incorporated with your Monarch. It can be incorporated with Ion. And the reason it's nice to have something like this is it allows you to have intraprocedural imaging for verification of where the nodule is. Has it changed? My partner George Chang had a case several months ago where the actual nodule on lung vision was not visible. So he did a simple BAL and later on got a repeat CT scan to confirm that the nodule was gone. So there are these, quote, ghost nodules that can come and go. The main unit addresses the image processing, so it has an AI algorithm. The tablet is a wireless system that's used for planning and control of the main unit during the procedure. And there's a passive board that helps assess where objects or lesions are with respect to space. So this is kind of a slide provided that demonstrates the different aspects of being able to obtain imaging intra-procedure. I think the image on the left there is kind of nice because it shows you what you can obtain where you use the preoperative CT scan to essentially segment your airway and define how you're going to get to the vicinity of the nodule. And then you do a C-arm spin, tomosynthesis, from 30 to 30 degrees or even sometimes wider than that to obtain the image that's illustrated there. The catheter then is adjacent to the lesion, and if you need to make minor adjustments as shown in the middle, you can, and you can do an additional spin when you have tool-in lesion. And the beautiful thing about this is now you gain confidence when you're doing your biopsy on fluoro, where the actual system projects a yellow mark over the nodule that you're going after and allows you to biopsy the sample successfully with tool-in lesion confirmation, which is kind of the hot or buzzwords on the street these days when it comes to peripheral lung nodule biopsy. So similar to how a CT scanner uses a computer algorithm to create this tomographic series of images from X-rays, body vision uses a proprietary AI-driven system that takes a series of X-rays, as I mentioned, from LAO to RAO, and allows you to have this kind of CT-like scan or C-arm-based tomographic scan. And so it's an agnostic system, meaning that you can use it with navigational platforms such as Ion, Superdimension. You can use it with probably the older versions of Superdimension. You can use it with C-arms, any C-arm. And there's a gentleman out there that I know is a huge proponent. He actually did a webinar not too long ago, Dr. Abramovich, of using the ultra slim scope to use the actual scope to get out to the periphery to the nodule and put your tools through the scope to obtain tissue. So that's kind of the nice thing about this system is you can combine it with your current setup. And the beautiful thing is it has a very small footprint, so it can fit easily into your procedure suite, which can sometimes be a rate limiting factor for some of us. So it seems like an excess number of steps when it comes to the procedural workflow. This, as with any kind of new system, is best practice when you have it and you do an in-service. But I'll go through just the 5 steps here. So in terms of the planning stage, this is where you load your preoperative CT scan. And the only reason you're doing that is to mark the airways that go to the pulmonary nodule. It helps segment the nodule and helps you define the borders of the nodule. And then you have your registration where you do a spin around the main carina, and then you isocenter the fluoro image intensifier around the lesion itself and do another spin around the lesion. Then you can use whatever navigational platform or body vision itself to navigate to the pulmonary nodule. And then you put your tools through and do an additional spin if you wish. This part's completely optional, but gives you that additional confidence that you're within the pulmonary nodule. And finally, you obtain your biopsy specimen with forceps, cryo, FNA, whatever it is that you like to use. So when we learned about this system, my partner and I, about 2.5 years ago, came up with the idea that, well, why don't we do a learning curve study? It seems like a lot of new devices are coming out, and one of the rate limiting things for a lot of institutions is saying, well, you know, our physicians may only do 30 to 40 cases a year. If it's going to take that long to become proficient at this, what's the point? Well, we defined our learning curve by when the point at which we would ask fewer than 3 questions from a representative that was present. And we found that even though we planned on doing about 50 cases because we thought it would take that long to reach our endpoint, we found, in fact, after approximately 8 to 12 cases, on average 10 cases, we had reached our learning curve. We went from an average of 23 questions pre-procedure or learning curve success to 0 questions afterwards. And there were some secondary objectives that we later on looked at. Now, a lot of these don't have statistical significance. Some of them do, such as radiation dose. It had decreased from 19.5 milligray to 1.5 pre and post. And our diagnostic yield, again, I should say that the p value was 0.03, and our study was not powered for this, but our diagnostic yield did increase significantly, at least clinically, from the mid-60s to the high 90s. So I like this system because I had a patient that I saw in clinic with my colleague. We kind of share patients, we see patients together, we do procedures on patients the other person sees. And this individual had a history of COPD and this inferior lingular nodule that had kind of persisted. She underwent navigational bronchoscopy after her serologies were negative. We live in Coxie country, so we always check for that. Our quantiferon was negative, and just to be safe, we checked some other fungal serologies. So navigational bronchoscopy was performed. It was inconclusive. The lesion persisted. It grew by about 1 to 2 millimeters. We sent her for TTNA. Surprisingly, and I say that because our IR colleagues are fantastic here, was also inconclusive. So we decided, you know, let's sit and talk to this patient. And I understand that this may not be something that everyone out there would have done, but we kind of went over our options with the patient, and we said we can either send you for surgical resection, continue with surveillance imaging, trust that this is nothing, and just keep watching it, or we now have this new system, robotic bronchoscopy system, and we also have body vision. We just got done with the learning curve study. We can put these 2 tools together and see if we can get you an answer. She had no issues with her prior bronchoscopy procedure, and said she went home and felt fine, so she was fine with proceeding, and that's what we did. So top left, slice A shows a coronal view of the inferior lingular nodule. Slice B shows where TTNA was done by IR. Here on C, we see where the virtual target is shown. This purple here is the anatomy border. One of the things I love about ION is it kind of points out structures that you try to avoid. And what you see here on the bottom, the middle screen is it's showing that the purple or the teal, sorry, I'm a little colorblind, the teal target is about 10 millimeters away. And at this point, we did not have a radial signal. So we used body vision, we did tomosynthesis, and I didn't include those scans here, but I do have the overlay down here. And as you can see from here to here, so slice C to slice E, we see that we were actually distal, too distal, and Ion was actually telling us we were still proximal to our target, which was a virtual target. So when we made the minor adjustments and retracted our scope and put the EBUS scope out, or the EBUS probe out for this 1.1 millimeter nodule, 1.1 centimeter nodule, we were able to get diagnostic tissue and diagnose carcinoid for this patient. So this is just one example. There's many others that we have experienced here, and I'm sure Dr. Hogarth has some as well. So before I turn it over, for my part, I think that body vision C-arm-based computed tomography is kind of the future, and it's present here now that it's FDA approved and we can use it, in that it allows us to have, for the first time, real-time intraoperative 3D imaging that helps to eliminate CT to body divergence, and just as importantly, to give us that visual confirmation that our catheter is at the nodule, and subsequently our tools are in the nodule. It's an agnostic system that can work with a different set of platforms regardless of what you have at your hospital. And for some of those that out there that do not have capacity for navigational bronchoscopy, body vision can also provide that platform for you. And as shown in our study that has not yet been peer reviewed, I should have pointed that out, the learning curve tends to be relatively shallow, and especially with the constant updates with the software that continue to be made. That's what I have, and thank you so much, and I'll turn it over to Dr. Hogarth.
All right, thanks. Can you hear me okay, Matt?
Yes.
All right, fantastic. Nice job, man. What a great presentation. Really enjoyed it, and thanks so much for supporting the SAB. So I'm going to add to that and expand on a little bit more, and then give some personal flavor to it. And so I'm going to talk about, again, our real-time guidance. This is my conflict. I know this is not CME, but this is my conflict of interest. It's fairly extensive, as you can see, and what I've done is bolded the ones that have anything to do whatsoever with peripheral bronchoscopy. Not that they're going to be part of this talk, but at least wanted to be able to focus your attention so you know where I'm conflicted. Alrighty, so why are we talking about any and all of this? Because, of course, as stated, all navigation platforms for the periphery have been dependent on that CT scan that was done prior to bronchoscopy. And as we know, in some cases, the CT scan done prior to bronchoscopy, the lesion might have shrunk in a short amount of time, and we might be actually biopsying a ghost, as Matt already talked about. And the issue is that real-time image-guided lung biopsy, if you want a high yield, I mean, this is where our IR guys excel. They see the needle go in the lesion. And when you see papers that involve, and obviously even just imagery that comes from cone beam guided bronchoscopy, and you see very high yields because, of course, in real time, you've localized the lesion. Obviously, TTNA is not, we already talked about all the complications, and so it's not something, nor is it a complete procedure because there's no EBUS staging. And cone beam's biggest problem, of course, is that the entry fee is an extensive amount of resources and money to make this happen. So it'd be great if we could obviously find something that would allow us to do this and work with the systems we already have. And as stated, this is where that visual confirmation of tool and lesion is key to unlocking higher yields, because it gives you that level of confidence that you're in there. It allows you to say, I am truly in the lesion, and therefore when I have a benign diagnosis, despite everyone's pessimism that it must have been malignant, you can say confirmed wise, I sampled it, and in fact, sampled it in multiple spots, so you can truly confirm you're getting it in several different locations. And pick your tool. And as we know, this is hard to accomplish on their own with the current platforms, as was outlined in a very nice review. I'm not going to spend a lot of time on this, was already gone through, but what I want to do highlight is trials that we're looking at body vision's clinical data, and their diagnostic yield, especially the Sasenia paper, that the real-time intraoperative imaging compares favorably, and this was in the body vision versions not associated with another platform, but by itself, just because you have real-time imaging, and it compares favorably to what you notice from the Pritchett and Ben papers that have also looked at cone beam versus obviously the various other modalities. So why are we telling you all this? Well, we're telling you all this because, of course, you know, we need some more data always, but the initial data that looks at a system that supports real-time image guidance through tomosynthesis gives you very nice yields and adds to what platform you already have, and gives us all, at least in our mind, what we're trying to strive for, because cone beam is this great. We've all seen the videos. I remember the very first time I ever saw Pritchett's presentation on cone beam and watched in amazement at the very real picture of a needle inside a lesion, and it blew us all away. But obviously there are cost issues. It's not readily accessible to all of us, or if it is, it's accessible on Saturday morning or Thursday night, and et cetera. And there's a significant amount of radiation exposure to the patient. We know it must be because when it's time to fire up the cone beam, everybody leaves the room due to the radiation exposure. And the workflows aren't perfect, but and people are getting around them, and they are interesting technologies. But body vision gives you this real-time intraoperative. So what I want to show here, here's the preoperative CT with that 22mm solid lesion. And then here's a body vision intraoperative 3D scan using this 9900 Elite. Now, see the comparableness. And that's clearly not the same as that pre-op CT, but in an LAO, REO, and in the coronal view, you can obviously see the instrumentation and see, and this is just a static image, you can see the needle inside the lesion. And you have comparable imaging using, and this is I think the most important part, and this was the thing that got me most interested from the very beginning, using the C-arm you already own and are already utilizing. And you get these interactive 3D views. This is where, and so I've been fortunate enough to be working with Lung Vision since 2014 and have watched the evolution of this technology from where it was to where it is now, and the ability, and I'm going to show you at the end actually where it's going in the next few weeks, and to be able to prove, everybody talks about the need for tool and lesion from a diagnostics, but I look at an image like this and then look at some of the trials that we're currently in at the University of Chicago and people in other places where someone says, I need you to prove to me you're in the middle of that lesion so that you can inject something or drop a radioactive seed or implant this or whatever. You need to be able to have this kind of confirmation, and to be able to do that with a C-arm. And then look at this video. This is a right upper lobe lesion and using the ion scope. Now, when you navigated, this is a navigation with RS Monarch under body vision, and then fluoroscopy augmented over the actual lesion. And then here's biopsy under just the body vision fluoroscopy augmented with an actual lesion using their catheter. And which again, you'll notice is the ability to see instrumentation going into the actual lesion in real time. And more importantly, because if we're all honest with ourselves, how often when you step on the fluoro pedal, are you actually seeing the lesion? And I don't mean just, if you squint enough and you hope that you see something move, but imagine if obviously under tomo conditions, you could confirm that's the lesion, and that's what that yellow ball tells you. So here, this is the cone beam CT view. Here's the body vision view using the GE 9900. So we've all seen cone beam as our so-called gold standard, right? And yet, tell me the similarities. They're very obvious. And so you get the benefit of being less costly, being able to perform in your bronch suite with any C-arm, not having to go to a hybrid room. You're not competing with any other lines of service for access to your C-arm. Much lower radiation exposures and no need to leave the room while you're actually firing things. And you get obviously comparable imagery. But also, this is where things get really interesting. If you look at some of the new 3D C-arms, so for example, here's the Siemens Seospin's 3D imaging. These are the real-time images. But here's the body vision imagery in the newest version that's coming out with the coronal, sagittal, and axial views and with the tool inside the lesion. This is using This is at the time using the Siemens as the standard C-arm, not with the 3D imaging. And again, not requiring you to buy additional pieces of hardware. So this has been looked at, of course. Nice article with Pritchett in the prospective analysis of endobronchial augmented fluoroscopic nav, and then obviously a senior article on the augmented fluoro with this an evaluation of the entire platform. And what I want to draw your attention to is the number. Is right. I'll draw back. Let me back it up right here. Target localization success verified with Rebus. Now we all know the limitations there, but the total number of nodules localized, and then total diagnostic yield. Now this is in the system where we didn't always have the ability to do the full tomosynthesis. You'll also notice the ability to go after much smaller lesions and still be able to get success in getting to those smaller lesions. I think importantly as well, by being able to look at localizations and that was confirmed by cone beam, so that you can have a direct ability to know that you are, sorry, give me 1 second. I apologize, pager went off, I had to deal with it for a second. When you're looking, this is, I think, one of the things that's very important. Localization is confirmed by cone beam. So, you know, if you're using a technology that is looking at tomo and saying, okay, can you get to the lesion? And does the tomo confirm you're in the lesion? Let's pull out then cone beam, which is thought to be the gold standard. And here's the localizations then confirmed when lung vision said we were there, results per patient, results per lesion. And then the diagnostic yield at the day of the procedure, again, getting up there higher, and then after follow-up, seeing a very nice diagnostic yield. We've already talked about this, but the procedure time in the various trials has been low using just the catheter, the radiation dose in the various multi-center trials, and then to put it into perspective versus the dose you see across a cardiac cath, for example. And then obviously partnering with all the things that you already have in this small footprint that was already discussed. So right now, the intraoperative 3D imaging, because for example, though lung vision has a nice catheter that you can use with any scope, or you could just use the scope and follow their line guidance, I've always paired it with my Monarch, and that's what I'm interested in using in the periphery. As you saw earlier, Matt's using it with the Ion. It's not about the platform. But as we know, and obviously on a prior SAB webinar, and from the data, you know, each of the robotic platforms have their issues with CT to body divergence. And the original version of where you had 3D imaging with lung vision allowed an intraoperative tomosynthesis with about an orbital angle of roughly 90 degrees from LAO to RAO, as demonstrated here. And so you had under the 3D imaging, LAO, coronals, RAO, and you got this summary 3D view in the latest version. That was released ultimately in 2018 with several updates. What's coming out now is the ability to take that C-arm and do a 180 view so that you can get the equivalent of almost CT imaging. In fact, actually CT imaging, because I'm going to show you here in a second, giving you ability to actually scroll through axial, coronal, and sagittal views, just like you did on your preoperative CT, but this is now intraoperative, and you're doing it with a simple C-arm, the same one you've always had. So let's take a look. So here's intraoperative tomo as it is today. A right lower lobe 12 millimeter lesion on the pre-op CT. You get the tomo. It's a nice view, but as you can all agree, it's a little blurry, etc. That's tomo, but I can all see the lesion, and look, we're in the lesion. So this is good. This is what I have 4 cases tomorrow. This is what I'm using tomorrow. I have an update coming soon, though. Apparently, I've been told in the next 2 to 3 months, which now I'm going to publicly say I'd like to see it in the next month, because what I want is this. What I want now is, and this is the version that's about to come out, where I can scroll up and down in my coronals or my axials and confirm that my tool is actually inside the lesion with a CT-based imagery. Again, here's this right upper lobe 8 millimeter nodule under tomo. You can see it. It's there. It's good. It's nice to see that it's there. It helps. It's great to have a C-arm and give you this imagery. And that's pretty cool. We all agree that's nothing like we have right now. But how about this instead? Scrolling up and down through it like a CT scan to mark that lesion, scrolling up and down in others coronals, sagittals, axials, to actually confirm where the dead center of the lesion is, and then more importantly with tools. Let's look one more time. Here's the intraoperative tomo as it exists. And here's where it's going. Using the C-arm. The part that's really cool, because this AI tomo, this really is where the data keeps getting better, because the algorithms keep improving as more cases get done, because the data keeps getting, I won't pretend to even understand machine learning protocols, but I will tell you, as I've watched the evolution, the revision of the imagery keeps getting better. So before I launch into that, I just really want to highlight, this is where, so this is out, if you will, it just hasn't been installed on several systems. But the ability to actually look at lesions intraoperatively, scrolling through imagery as if you had a CT scan, and yet all you have is a 180 sweep with your C-arm that you already own. Now, same caveat that Matt gave about non-peer-reviewed single center. So let me give you, we started combining Auris and Body Vision together. This is retrospective evaluation of our first 45 cases. It's one user's data, mine. It's not been peer-reviewed, so feel free to slaughter it and murder it for all you want. Clearly right upper lobe predominant and left upper lobe being the two sort of most locations. The average size was 16.1 millimeters, plus or minus 7.8. So going after some small things. The total robot time, so that involves meaning adding in lung vision plus driving and so forth. And we are a teaching center, so we obviously also work with our fellows. And then the total procedure time, because inevitably there was EVA staging as well too. So 45 biopsies done right up front, depending on how you want to define things. That's why I'm going to put these multiple things here. 32 totally malignant, 9 with benign histologies, 4 that were non-diagnostic, so normal tissue or atypical cells, and 1 ultimately did end up being cancer. 1 was resected and was scar. So we'll forget that side of the box, even though some people could decide to use that definitions. I'm going to stick more to the right. So if you only go with the what's malignant and what's a specific benign of granulomas and pneumonia and amyloid, then you had a 78% yield on the most conservative approach. If you take the 4 with follow-up supporting that benign etiology, you get up to about 87. The 2 that had follow-up CTs, which I can tell you from the time the slide was made to now, these have resolved. These were quote chronic inflammation, giant cells, but not granulomas. So if you include those, you got the 91% yield. And when I was first starting these, I did not have the 3-dimensional spiraling view version that we've seen so far in the video. So we'll see if my numbers change as the software keeps evolving. So this is one of our cases where we do have the 3D views. You can see we've navigated, we think we're relatively near the lesion. It's a very small lesion bracketed by vasculature, but you can see the needle out there. And there was no direct airway going to it. And on our first pass, because we were able to actually confirm we were inside the lesion, we diagnosed this person's renal cell. They also had a colon cancer, had a history of lung cancer in the past, as well as head neck cancer. And it was as yet not diagnosed renal cell that was proved to be the met inside the lung. So it's a very tiny lesion, but there it is. When we were actually taking the biopsies, what you'll see here, we'll ultimately turn some of these pathways off, and the video is not that super zoomed in, but when we first looked, you can see we're a little bit to the side. So we made some minor adjustments, and now we're there, and we know we're in the center, and if you spin the C-arm at all to any of the LAOs or RAO angles, you'll confirm you're still in the yellow ball. And the reason I know the yellow ball is real is, and sorry, we changed the gantry a little bit, that's why it jumped. The reason I know the yellow ball is real is I'm the one who marked that 5 minutes ago. Now, one other quick one. Here's a when we ultimately did the CABT lesion, this was a 7 millimeter right upper lobe, and then ultimately the 9 millimeter left lower lobe. But I want you to see, this is the first version of the CABT, where you can see the small little cavitary thing. That's what we were trying to biopsy. That's what it looks like on the pre-op CT. Obviously, on the new version of AI Tomo that I'll be receiving soon, and others who have the system will be getting soon, This is where instead of rolling around it and getting the fuzzy view, we will be able to obviously scroll up and down, similar to a CT scan, to be able to actually see the lesion in multiple fronts. What that does then is when you step on the pedal, that little ball is always there present, and you know where it is because this is the lesion. You just marked it. And this was actually a MET from their laryngeal cancer. And they're like, so we backed up because we knew we were going to slide off to the side. We were able to make some more adjustments here. You zoom in a little bit more. So we took it at a different angle just to confirm. And then I'll jump forward here. And then we went over to the other side as well. What it adds, and I think, you know, one of the values is that when we all know where we are, I think we all biopsy it a little bit more aggressively as well. At least that's been my sort of anecdotal experience. You know, we all there's a reason why we like that Rebus view. It gives you the confidence to know that you are at least there. And so you'll take multiple passes. You will be more aggressive with your sampling because you feel confident that you're there. Well, what gives you any more higher degree of confidence than actually seeing the lesion in real time as you've spun around and confirmed it's there? And then every time you step on the pedal, no matter whether you're using a Monarch ion, a thin scope, a catheter, whatever, that yellow ball for once is actually where the lesion is located, not being reintegrated into someone's virtual platform, but actually right there. And then obviously combining that with everything you know about your robot in regards to maneuvering it, etc. So that was my final slide. Here's the University of Chicago. If you find yourself in our neighborhood, please swing on by. We'd love to have you. There's my cell phone. There's my email. If people want to reach out, I'm happy to discuss anything. I'm happy to share my slides too. I don't think Lung Vision will care. That's it. Thank you so much. And then we're going to answer some questions. The board that goes behind the patient's back for Lung Vision is compatible with the next generation magnetic field generator that also goes behind the patient's back. If what you mean if I assume you're asking that about for the window field generator, that's the newest release within the Monarch. The answer is yes. The window field generator goes under the bed. This board goes above the bed, the beaded board. It obviously works with the ion. It would work with a thin scope. As Matt pointed out, the older versions of EMN with superdimension would work. The newer one, because the FluoroNav requires its own board for its own localization, would not be compatible there. And then another question was, what mobile C-arm do I use? So I just simply have I have a GE1. We had to get a new C-arm a couple of years ago. We had a 9900, it died. We got a GE1. But that's just the nature of my medical center. That's what we got. The thing that's really interesting, I know some centers have been using who had a Siemens Sios and are not using the 3D component of it, or just using it as a simple C-arm. But the short answer is it'll work with any C-arm, period. That is the definitive answer from the company. If you've got a C-arm and it has any ability to have, I guess it can't be so old that it doesn't have a digital out. You've got to be able to take the data out of a C-arm. So if you have a really old one that has no output, then you might have a trouble, but that's about it. I don't think they exist. So agree, Matt? Anything to add to that one? Oh, you're on mute, dude.
There we go. Sorry about that. We have the GE OEC 9900, and it's been very easy to incorporate and use from day one. So yeah, I think that's the beauty of the system, is that it allows us. You know, I think when we spoke a couple months ago, and you told me you were using it with Monarch, it was kind of a light bulb where, oh, this is truly agnostic. You can use it with both robots, and regardless of which robot you have a preference over, we all want intra-procedural confirmation, and so you can augment it with what you have.
Okay, let me see. There's some other questions that have come up. Let's see. Okay, what else? Okay, the target generated by Lung Vision is a static target. how do you take into consideration movement of the nodule during inspiration and expiration? Matt, how are you guys handling that?
So there's different ways of doing this, and it depends on whether or not you see it on the fluoro. The nice thing is that you do get that yellow overlay, and if sometimes with Body Vision's tomosynthesis, once it's marked on fluoro, I'm like, oh yeah, you can actually see it there. You know, you can hallucinate a little bit and visually tease it out. And so when that's the case, then I know. There have been times where I've had to put my forceps out 1 centimeter, and I'm like, oh, I think I can go. I could push a little further, or vice versa. And there's always the option of doing an inspiratory breath hold to kind of make it a static environment for 5 to 15 seconds while you do your forceps or needle or brush or cryo, whatever you prefer.
So one of the things too is, you do that tomo spin at an inspiratory breath hold. So as like Matt said, just do an inspiratory breath hold at that stage, and you're not going to do it for very long because you've obviously gotten close. You've made adjustments with whatever your navigation platform is to steer the end of the scope and your instrumentation towards the yellow ball. As you place it out there, I quickly flip LAO and RAO just to confirm that I'm really not going above or below, take my sample, let the patient breathe, etc. Frequently, of course, depending on the relationship of the nodule to the airway and the optics that you have. So like when I'm using the Monarch, I can obviously see my instrumentation go out, and I can see that I've gone through the wall. And so I see that I'm going through the wall, and I see that it's going into the nodule. So, and then if anything's moving, they're all moving as a unit, because obviously the scope is inside the airway, and the needle, I see it go through the wall, blah, blah, blah. And now I see that it's inside the lesion. Like Matt said, the beauty of this is if I'm not sure, let's say you're just not sure, then do another spin with your instrument out and get the three-dimensional view that shows that, no, I'm actually inside the lesion. That I didn't, because look, this is a problem, right? You go through and then instrumentation bounces off. You didn't actually penetrate. And so prove it. And if you need to, it's another quick tomo spin. But the tomo spin takes 15, 20 seconds. It takes about 30 seconds to process, if that. So, 2 minutes at most to help confirm where you're at. I think you got 2 minutes on behalf of your patient, right? So let's see. Most conventional CMs are unable to rotate 180 degrees. Can we still get that CT type imaging with less than 180 degrees of rotation? That's a good technical question that I don't know if I have the direct answer for. So I will punt that one to the lung vision people on the technical side of it. Unless, Victor, do you know the answer to that? And if you don't, if whoever sent in that question wants to text it to me or email it to us, I'll connect you with the technical side. Unfortunately, because of time changes, a good chunk of the brains that are running the computer underneath are in Israel, and it's the middle of the night there. So that I think they chose sleep over listening to Matt and I. All right, let's see if there's any other specific ones in the chat. Cool. Oh, I got one. AI Tomil will still work less than a 180-degree spin. So there you go. I just got someone. One of the brain power was on the talk, and I just got. And actually, the true brains behind it, and the CEO just texted me and said yes. So there's your answer. Yes. I kind of figured it was, but I didn't want to be wrong. And so now you heard it quite literally from the CEO. The answer is yes. So yay. I guess the other thing too, Matt, I mean, I really can't stress enough, and you highlighted it really well, but when we first started talking about bringing lung vision into our bronch suite, there was the groan of, my God, we're running out of space. There's more wires on the floor now. Dear God. Except the only, quote, wire is what comes out of the back of the C-arm box to the lung vision box. That's it. Everything else is the wireless tablet. It's actually refreshing that someone decided that wireless and Bluetooth was, or whatever it is that connects it, as opposed to yet another cable for someone to die on in my bronch suite. What's been your experience about just using the tablet?
Absolutely. So I think it's smaller than a computer laptop, and it's on a stick. So you just walk in, after I reached my learning curve, I've started allowing some of the fellows to just do it. And the other,
Yep.
so it has a very small footprint. You don't have to go in on a Saturday morning to use your cone beam CT or compete with interventional cardiology. And the other positive, we did do like a 2-day trial with CEOS, and it gives you great images, don't get me wrong, but we literally had to step outside the room during the spin due to the radiation exposure, and not all rooms are prepared for that degree of radiation. So there's a lot more footwork, legwork that goes into preparing a bronch suite for something like that, as opposed to lung vision and utilizing your own C-arm.
Right. I mean, I guess if you're not remotely ever using a C-arm ever in your bronch suite, then this would be a new phenomenon. But I think a large amount of us have a C-arm around. Maybe you degree at which you use it. I think actually one of the most fascinating things from your learning curve study was the reduction in the quantity of radiation utilized. And this is all markedly less than the radiation that's being done across multiple other platforms. And I mean, from using cone beam, or even when we compare ourselves to like interventional cardiology. And obviously not just from a patient perspective, though that clearly is paramount, but how about us?
Right.
You know, you're all leaded up, but you know, I don't really plan on glowing in the dark by the end of my career, you know, so, right?
That's right. No, you're exactly right. And you know, I think it all just goes back to, there was a really nice talk that you did with Dr. Saseni and Dr. Badra, where when you have tool-in lesion confirmation, like we can do with body vision, our negative predictive value goes up. So once we go to our tumor board, or our pulmonary colleague who referred the patient to us, we can say to them, it was negative, it shows granulomas. I can say it with a higher degree of confidence.
That's right. Agree. I don't have any other questions that have popped in. Matt, you've got any other thoughts or anything else that you want to question? I will make one plug down below. You earlier mentioned George, so there he is, and with Dr. Oberg as well. For those of you that will be in San Francisco, just if no other reason, honestly, I'm going to ATS just because it'll be great to see people. I mean, with all due respect to the ATS meeting, but the SAB is hosting a very nice event. Social, of course, which is always awesome, and then followed by an educational presentation on lessons learned in growing your bronchoscopy skills, program, and career. I think moderated by Dr. Oberg and Dr. Chang, and I think what'll be great about this, no matter where you are in your level of training, and I'm sorry, not just training, but also your level of work, and even if you're a very seasoned senior person with an advanced program with multiple operators, you know that there's always ways to keep growing and keep getting better. And if nothing else, the competition's growing and getting better. So as soon as you become static, down you go. And I think this is a great opportunity at a gorgeous location, not that far from where we'll all be around at the Moscone Center, and come spend some time with us.
Fantastic.
Emily, anything else on the shopkeeping side of this?
No, thank you everyone for joining tonight's webinar, and thank you both to Drs. Hogarth and Novari for putting on the presentation, also to Body Vision Medical, and we hope to see you all in San Francisco. Good night.